The next speaker is Dr. Vu, who will speak about the Small Annulus TAVI, also a subject matter of debate. We're going to see some trials, I think, yeah?
Yeah, thank you. So after I listened to lecture from Kwan Lee, I have to consider again my presentation today. Yeah. Um, Small annulus, we have some definition, definition from the MDCT based on the CT scan, and we have the annulus diameter less than 10 to 23 mm, and we have the area is less than 430. It depends on the trial. So we have a lot of definition of that, and we have the extreme very small annulus. That annulus area less than 314 mm square and mean annulus diameter less than 20. This is very small annulus in daily practice. So why small annulus matter in TAVI? So the first thing is we listen to the previous discussion about the high risk of prosthetic patient mismatch. I mean the PPM. It means the high gradient after procedure. So some data say that with the small annulus we have a higher gradient post TAVI, and also we increase the mortality sometimes, but we have to consider maybe more discussion about that. And the valve choice, some data say that I will show you later on about the valve size. Self-expandable valves would be the better balloon expandable valve in terms of hemodynamic post TAVI. So also we have increased risk of annular rupture on injury because it's a small annulus. So we have a lot of matter to concern about when we do the TAVI in the small annulus. And also we have very common problem in long-term follow-up and lifetime management is that the coronary access with the small annulus usually more difficult than the nominal annulus, and also valve in valve in the future with the small annulus also very difficult and high gradient to compare to the normal one. So usually they have to use a basilica or unicorn or sometimes the shortcut device, as we see in the previous lecture about the to reduce the ppm of the valve in valve in the small annulus. So how about the prevalence of the small annulus in the Western country? Is the data from the Germany is about 20, is about that 20%, no, 12% of the patient with small annulus in the Western country, but in the Asia is more frequent. It's about 60%. In our center is about 50% of small annulus. So we have to concern about that. And this is a smart trial. All we know that the smart trial 2 years just presented this year. So this is over 700 patients with the small annulus. Definition is about less than 430 mm square by MDCT. And we have two arms. The first arm we have self-expandable valve with Evolut, and second we have balloon expandable valve with the Edward Sapien random 1-1. And this is the final result of the 2 years follow-up. We see the composite endpoint is not significant. I mean, it's the same when we compare the self-expandable valves and balloon expandable valve. But we have the hemodynamic gradient much better in the self-expandable valve. So that's the truth. That's a number we have to follow. But the composite endpoint not different between the two groups. And this is 2 years, so we expect for the longer time, but we have to wait for time. But this is the registry from Ocean TAVI 5 years just presented this last month. They have some patient with the Evolut Pro self-expandable valve and Sapien 3. They found that after 5 years, we have the similar result of the smart trial in 2 years. It means that the balloon, the self-expandable valve in terms of a hemodynamic is better than the balloon expandable valve in terms of hemodynamic pressure gradient after procedure and then after 5 years. But we still have the same clinical outcome that heart failure, stroke, hospitalization, the same in the both group of the even with the both vowels. So it means that gradient is different, but the composite endpoint and hard endpoint is similar at 5 years. So in daily practice, what we do, we have some steps to do lifetime management, especially for the small annulus. The first thing you see here, the annulus sizing. The first step, annulus sizing. And if we have small annulus, we might prefer for the cell expandable valves, if possible. I mean, if possible. If of course, we have to consider another thing about the coronary obstruction risk, and we have to consider the pacemaker risk and future risk plan estimation, and also the next TAVI valve and valve, something like that. So we have to consider all. But the annular sizing is the first step in the daily practice. And another thing is about the technique. Usually, if we implant the valves, even with the balloon expandable valve or self-expandable valve, if we implant higher than usual, we have the larger EOA. It means that we have the better hemodynamic result post TAVI, and we reduce the permanent pacemaker implantation. But also we have to check up with the risk of coronary obstruction. Also, we have the risk of sinus sequestration after the TAVI procedure. So we have to count it on. But in terms of hemodynamic, we should implant the valves higher than usual a little bit. We have the two techniques here. We have the curse overlap. We familiar with the self-expandable valves, and we have the radiolucent line. We have some technique to implant it high at 10 or 90 or something like that. And and this is the slide that Dr. Swanley has we have small discussion about the post dilatation of the valve. So in this is the in the left hand, in the right hand side, we have the balloon expandable valves with the small annulus about 324 square. And when they do the first balloon with the balloon expandable valves, the diameter is okay. But if we do the same volume, I mean the double tap, they call the double tap technique. The second one similar but lower a little bit. I mean our inflow a little bit, and we have the better result of the in term of the diameter of the valve, and maybe in term of the hemodynamic. And also in the left-hand side, some case when they do the small annulus, they recommend the post-dilatation for the self-expandable valve to get the hemodynamic for the patient and higher implantation for that. So this is the algorithm that for the TAVI in small annulus that I suppose I just suppose for myself, but I don't know. Everybody here maybe you have different opinion, but if we think of if we have the patient with severe aortic stenosis with small annulus less than 430, and if we choose balloon expandable valve, I prefer all the case with the pre-dilatation, not oversizing, but we just show the balloon, and we have a lot of, I think I have a lot of information about the balloon pre-dilatation when we do the balloon expandable valve, because we can see we take the valves, paravalvulic, the coronary obstruction or something like that. A lot of information before we implant the valves. And the implant depth should be 20, 80, or I think the better is if we think about 90 or 10. But if the patient young, maybe we should implant deeper than this. But if the patient, we just consider a small annulus, maybe higher the better. And also the double tap technique, I recommend for that. And if we choose the self-expandable valves, maybe I also recommend the pre-dilatation. In our center, if I do the procedure, I would recommend all the case with the TAVI suit pre-dilatation. I would like to do the TAVI procedure similar to the PCI. It means the pre-dilatation and post-dilatation to get the better result. Of course, we have to have some risk to do pre-dilatation and some risk of the post-dilatation, but I would choose the way to go like that. And the implanted depth with the TAVI with the self-expandable valve should be 1 to 3 mm, and post-dilation with the balloon might be appropriate size, not oversizing too much, because we sometimes we have the injury of the annulus rupture, so even the stroke. So I think that the balloon size is very important. So all the algorithm like this, I think I will get better EOA, reducing PPM, low risk of coronary obstruction, also the pacemaker and the rest of the. And so small errors, according to the data so far, we maybe if it is not the if we don't have to concern about the pacemaker, concern everything, we choose a self-expandable valves, high implant, avoid oversizing, and protect coronary and plan for TAVI in next future. And this is the last slide in the ECI 2024. If we have the small annulus, we have to have team discussion, of course, and we think about the supra annulus. For the if we think about the TAVI, if we do the open surgery, we think about the annulus enlargement surgery. But I think not many center can do this procedure. So thank you for your attention.
Thank you very much. Are there any questions? Maybe I have a question for all the speakers until now. I just Googled a little bit because it's better than PubMed today because of government funding, PubMed is no longer up to date. It seems that half of our TAVI patients pass away after 5 years. So yeah, that's what I just one of the rate. Maybe it's not true, but what is? Can you comment on that, Kwan? Because
Yeah, I think half is a lot. I think it really depends on which cohort. Let's say if your country does only 75 and above, then it could potentially be true that half of them are dead within 5 years. But in the United States, it's definitely not true.
okay.
Yeah, they tend to be.
I must agree. It is the 80 plus that half of them pass away. So we probably have to tailor the way we think about this. Yeah.
But I think average humans at the age of 80, if you
By
track
definition,
yeah,
you pass away. Are there any questions for this panel? Yeah.
I
Yeah,
just want to make a comment. You mentioned something about annulus expansion surgery. That was proposed by someone from Michigan, a Chinese surgeon. Yeah, Boyan. But his published results compared to what we have seen in real life by other surgeons trying to learn his technique are definitely not the same. We have seen quite a bit of severe mitral regurgitation after an attempt at a root enlargement for the procedure. So I think there's clearly a learning curve, and it really remains to be seen whether there's a technique that can be well adopted by many people around the world. I don't know what do people do that in Europe and here?
We just adopted since 2023, and in our hands, I think it's a very feasible options. Yeah.
So you have good surgeons here that were able to do it without any problems.
Yes. Yeah.
So I have one question to Dr. Wu. So when you do the balloon sizing, do you open the valve first or not to repair the valve?
Yeah, of course. Always we have to prepare the balloon. I mean the valve first. Everything on the table. So and we do the balloon. In case of we have acute AR, so the blood pressure down, and some we have to do every fast. In over 100 cases, we have 2 cases with AR. 2 cases with a severe calcification with the balloon and pressure down about 60 or 50, and everything we have to very fast, very do fast.
But this is very rare. It's very rare to
Yeah.
happen.
Yeah.
If you change the size of the valve, we have to open another valve. Is it? When you do balloon sizing,
Yeah.
if any change of the size of a valve, so we need to open another valve.
So yeah, that's also a good question. So usually with the balloon expandable valves, we can change the volume a little bit if we think about that. But for the cell expandable valves, we cannot prepare all 2 valves at the same time. But usually when we have some risk, we usually we underside a little bit of the valves for the safety reason. Yeah. So any comment from this question from Dr. Kwok? Dr. Rosalie, can you?
Yeah, I think that's a issue, but quite often the borderline cases are not very often. The planning is quite good nowadays. And then it's as you say, if it's balloon expandable with just minus or plus volume, so that covers it. But the self-expandable, usually we do, it's like borderline, and then you see the calcification, you see just above the annulus and the sizing. And if let's say there's lots of calcification like bicuspid and it's more conical, then we tend to undersize a bit. So at least we don't have to open the second valve.
It's very rare. What basically happens is we had it once that it took us more than 1 hour and we had to go retrograde transeptal. We had to throw one sapien in the garbage, but because we were too confident. So probably it's always safer to cross the valve and then open, because it takes a short time to prepare the valve, most of the valves. Yeah. You want to use this microphone?
I just comment about your you just mentioned about the what the patient underwent the TAVI is passed away after 5 years. So I think the different cohorts a different result, and we also the based on the frailty patient and comorbidity. Yeah. So our question is recently is the TAVI patient is a longer life expectancy. So the technique for prepare the next redo TAVI. So the what kind of device Dr. Gandhi just mentioned above, but the question is that we measure is a membranous septum length, and then we make a decision deploy deeply or shallow. So in your clinical practice, so you based on that, you make a decision deploy deep or shallow for facilitate the next redo TAVI.
Who wants to answer this question?
I think it depends on the lifetime management. What is the issue that you're going to face more? So if it's a coronary issue, then you may want to implant a bit lower, knowing that you may get a higher risk of permanent pacemaker implantation. But I think that's still acceptable. But if the risk is not high, the risk of coronary access and closure is low, then I really implant as perfect as possible if I can.